Tracy, I know you love talking about complications and safety, one of your passions. Tell me a little bit about how you feel about that.
Well, as I've said before, I think if you can't handle a complication or potential adverse event to any treatment you provide, then you shouldn't be doing it.
Absolutely.
So that's a basic thing. But let's assume that we can. Let's assume that those of us who are in the industry do know how to deal with those complications. That's down to, again, knowledge, experience, training courses, and ongoing dialogue with colleagues. So, and having our CPD, so we know how to deal with these complications. So I think that we could categorise these into different sections.
Brilliant. Come on, let's get categorised.
Okay, so things that we may, it's amazing how a patient might perceive a side effect or complication when we don't.
Good point. So what is a complication?
Well, a complication is something that can cause serious harm as far as I'm concerned.
Yes.
As an expected side effect or an expected thing like bruising, short-term swelling, redness, that to me is not, it's more hand-holding a patient through that, consulting them well at that first initial meeting and giving them very clear instructions afterwards. So that's, we say an easy bit, but actually there's that when you're running a clinical practice is very important because it will minimise the number of calls or emails you get through from people who've got a bruise, got swelling, got this or that, and you haven't actually addressed that before they've left the building. So, but those are easy ones.
So any tips to counselling?
Yeah, I mean, I don't want to tempt fate here, but I was boasting, hardly any of my patients ring back with queries because I counsel well. I talk to them during the treatment about what they're to expect. I will go into detail about things. I will actually say to a patient, please do not go away, I know you will, but don't go away and overanalyze my work, particularly with fillers. It will look asymmetric a little bit. If you look hard enough, you'll find something you don't like. Please don't go away and overanalyze it. Wait until we book your review. Trust the process. And trust me. And we don't get any kind of queries. People do trust you. They've got their aftercare. They've had their consultation. And they're fine.
So it's all about building trust. So
I believe it is. I think if a patient trusts you, they will do the most, well, you know this, Adrian, they will actually let you take the lead. So if I'm doing, and again, I'm not going to digress on this, but this is part of the conversation, if you've actually got a big strategic treatment plan with a patient, and some of mine have got big treatment plans, multiple fillers, over time, toxin, they've got to trust you that you're going to do the right thing. So that's what you can sort of stop that kind of person worrying.
And presumably you've had patients that you've had for 20 years, have you?
Yeah, 27, 28, some of them. I treat some 80-year-olds. In fact, I treat 2 90-year-olds.
Really?
And why not? Why not? I mean, that's another whole topic. You know, are you ever too old to have cosmetic treatment? In my book, no. But so that's how I maintain that loyalty and trust, and I'm honest. If I think that something's risky or shouldn't be done for whatever reason, and again, that's another whole topic, I won't do it.
Okay.
So let's go on to really serious complications. I think the things that we consider to be more serious are vascular occlusion. And again, we can talk about that. And nodular, delayed nodules.
So more with fillers, maybe?
Oh, yes. Fillers more than... I mean, a toxin treatment, I think a lot of the time, if there's a complaint with a toxin treatment or a complication, it's either, not always, no, by no means always, but it's often inexperience. Not assessing that patient and understanding what might happen if you do that. And or diffusion, as we know. And they will wear off generally. So we know that the reassurance for a patient, though they wouldn't be happy with a complication from a toxin, is often that either it will wear off, they won't be happy during that time, or you can either correct it some way.
So I think that's the thing. So with toxins, the effect is temporary, which is really, really important.
Really reassuring.
And also, if you know your anatomy, you're unlikely to get any of the problems.
Definitely.
Fillers are more prone to problems, aren't they?
Definitely, which you can't predict. I think toxin, I don't
it's
even see it's more predictable, and it's more an aesthetic complaint, meaning why is one eyebrow up here, and why, and
Yes.
hopefully those of us who do
Yeah.
great treatments don't get
Yeah.
that.
So what I sometimes say, Tracy, I don't know if you agree with this, is toxins a bit more like baking. If you follow the recipe, it's going to work. Fillers are a bit more like cooking and a bit more artistic.
Very, very artistic.
Yeah.
Very artistic.
And more potentially greater rewards, but you
Yeah.
know, your food might taste pretty terrible sometimes.
And that's something that I would like to explore in terms of technique and the way you assess.
Yes.
But with side effects, yes, vascular occlusion
Yes.
is something any high volume injector, meaning
Yes.
somebody who's been doing a lot of treatments
Yes.
over a lot of time would have seen this.
So no matter how good you get,
Yeah, absolutely. It's not because, of course, again,
Yes.
training, it's all the things
Yes.
we discussed, will minimise.
Yes.
But occasionally, you will be caught
it's really
out.
unlucky.
It is unlucky, and you just need to know how to deal with that. Recognise it quickly, deal with it well, and we have a box
Yes.
of our immediate,
Yeah. So talk me
kit.
through, Tracy, the signs of vascular occlusion and how you manage it.
Yeah, well, they vary a little bit depending on whether venous or arterial, but actually it's normally evident at that moment if
Yes.
it's an intravascular event, an immediate one. So it normally will present as pain on injection. Now, injections aren't comfortable, are they?
No.
But
No.
the patient will react. They'll go, ooh.
Yes,
That-
you have a sudden
Yeah,
pain.
you'll normally get something that gives you a little bit of a clue.
Yes.
Particularly nowadays that we don't use anaesthetic,
Yes.
so you'll get a clue. It will blanch. Normally
Yes.
you'll see a blanch.
Yes.
And then if you wait long enough and you just wait and watch, it will often eventually look a little bit dusky. It will look like a bruise.
Yes.
And a lot of practitioners actually fall into that trap of thinking, oh, it's a bruise.
Yes.
They haven't seen the blanch
Yes.
bit, or if they have seen the blanch, they're not experienced enough to
Yes.
understand what that means.
Yes.
And you just see this duskiness.
Yes. Where have you seen it most often? What areas?
Well, I've advised on people that have had it done. So it's not, I want to make it clear, it's not necessarily what we've done,
Yeah.
but I've
Treating other people.
lips,
Yeah.
lips, definitely.
Yes. Yeah.
Top lip, I've seen a fair few times, definitely, again, from referrals. The other one is here, a place where people inject so often the top end of the nasolabial
Yes,
fold.
yeah,
They go
absolutely.
deep
Yeah.
and affecting the whole side of the nose, and that is a very nasty one.
Yes.
Very, very nasty, and can be potentially very severe with a threat to vision.
Yes.
So that is a very nasty adverse
Yeah,
event.
because the artery runs up there, the branch of the facial artery,
Absolutely.
and that is a danger spot. So
Very dangerous.
probably either be superficial or deep,
Yeah.
but not
Yeah,
in the middle.
Yeah, and that one is one where a lot of our practitioners, particularly years ago, we always used to chase nasolabial
Yes,
folds. We don't
yeah.
do it so much anymore. That's a really dodgy one because it's an area that people treat a lot.
Yes.
And also the more advanced techniques that go
Yes,
to, people
yes.
are putting products deep on this
Yes,
alar group,
yes.
and you have to be quite
So if it's
respectful.
deep, it's got to be on.
It's got to be on bone.
On the bone, yeah.
And you've got to know what you're doing.
Absolutely.
So those, and again, I won't go through the sort of protocols, but we should all have an occlusion protocol in our clinics.
So just
when
tell me
we
a little, sorry, just go back. So the difference between venous and arterial, you mentioned, Tracy.
Yeah, I know. I couldn't go into detail about this. Maybe you
Yeah,
could,
yeah.
but certainly that it presents slightly differently.
Yes.
And I'm not quite sure. But the main thing is that if you actually recognise that you've got something that doesn't look quite right, I would
Yeah.
say dissolve, dissolve, dissolve.
Can you do any, I was asked this the other day, can you do any harm with hyalase?
Not really. I mean, I don't know what your feeling is as a plastic surgeon about this.
Yeah.
But there's, of course we know that it will dissolve any filler in it's like a nuclear warhead, so it will
Yeah.
dissolve any
Any
filler.
filler, any
yeah,
filler.
yeah, filler,
Yeah,
yeah.
yeah.
But it will dissolve
Yeah.
anything in its vicinity. So if actually you've got a face that's beautifully filled
Yes.
and you start to, you're going to end up with a mogul field
Yes.
of
Yeah.
fillers. So that is
Yeah.
a more practical one.
Yeah.
There's an allergy risk with hyalase,
Yes.
as we know, and
Have you
that's
ever
why.
seen that?
No.
No. Touch Bill.
No, we take very detailed allergy histories, but we're always aware and we're always prepared.
Sure.
But I think the main risk really, people say, does it dissolve your own hyaluronic acid? Oh dear, am I going to be? I think the main thing is that actually you risk assess, don't you?
Yeah.
You were doing a risk assessment. If we feel we might have a vascular event, we have a duty of care to dissolve.
The most important thing is to dissolve.
But it's the delayed adverse. It's when you're doing a treatment, it's not noticed that there's a problem.
Yes.
Off they go.
Yes.
And they may be called in a day or two. It's painful.
Yes.
It looks bruised, but it's really, I always say to my team, if somebody rings up my front of house, if somebody rings up and says, it's really painful, the alarm bells should go off, because filler should not be painful.
And bruises do not hurt.
They don't hurt.
No.
If you've got a painful bruise, I would bring that patient back pretty damn quickly to have a look.
Because obviously bruises caused when you pierce a blood vessel and blood escapes into the tissue. That is what a bruise is.
Yeah.
But if you have ischemia in the tissue,
yeah,
that can also look like a bruise.
Yeah,
can't
it can mimic things.
It can mimic a bruise.
Yeah.
So one thing that I want to make people aware of is if you do have an intravascular injection, the site of the ischemia doesn't need to be. Isn't always where you inject it, is it?
Yeah, it can be distant.
Talk me through that a bit, Tracy.
Yeah, it's all to do with if you directly inject into a vessel, of course a bolus can travel through the vessels, so it will have impact somewhere else. But if you think, as we know, vessels supply different areas. It's like a hose pipe with holes in it supplying different areas. If you block off somewhere, you're going to have impact distal to that. And that's why, certainly, if someone's injected here and we get some sort of event that's higher up, it's just because you've just literally stood on that hose pipe and you've blocked the supply. And yes, if you've got an event on the lip, it can literally extend quite significantly. And the cardinal symptoms of and signs, symptoms, pain. Pain is the one, but it will. If it's left to its own devices, as we know, all kinds of complications can go on and on and on. But pain, ulceration inside the lip, so a few days after injecting, normally the process will be something that looks like a bruise, but it's not. It's painful. It will then gradually evolve into the skin breaking down, ulceration on the mucosa and inside the nose. I mean, that is so excruciating. And that's often when we pick these events up, when people haven't, or practitioners out there haven't been aware of what they've got, and you then, as a next person down, you see these things happening where they present with mucosal ulceration and pain. And then
is it too late to hire laser?
I still do it. I still do it. I mean, of course, the quicker the better. I still do it for what it's worth. I think that's best practice. But by then we're into the antibiotic cover, antiviral cover, all the other things. But I just blast the whole area.
Okay. So if we've got to go through Tracy's top tips for occlusion are: be aware.
Watch, inject slowly, prevent first. So know your anatomy.
Know your anatomy.
Inject slowly.
Inject slowly. If you anything abnormal, stop.
Stop immediately.
Okay. Then if you think you may have an occlusion, keep them in, watch them.
Do not let them cancel. Right. Cancel the rest of your clinic.
And your evening sometimes.
Cancel that. If you need to go to somebody else that's more senior in your clinic, do that. Second opinion always. Go higher. Always go higher. If you haven't got that, work on an assumption that it is an occlusion. Don't panic the patient, but be clear. I think you've got a little bit of pressure in this little vessel here. Please don't worry. I'm just watching it. Give them information. And then before I would have rubbed it, but do you know what now? If in any doubt, I would say just get your process going quickly.
And
dissolve.
Your process, talk us through the process quickly, is?
I would dissolve everywhere that the treatment has been done, and even around that whole area. I wouldn't pussyfoot around
it. A bit
it.
wide, because basically high lace doesn't do any harm.
No.
So you might as well, it's only going to treat the hyaluronic acid, isn't it?
Correct.
So, there's no harm in doing more.
Yeah. Treat the whole area.
Yeah.
Explain to the patient gently what you're doing without alarming them. It hurts, it's stingy, you know, it's uncomfortable.
Yeah.
Massage it so you get that hyalaise getting to the parts where it may have affected. So basically go in the area that looks affected.
Yes.
You know, and all around the area. If you know your anatomy, you know pretty much where you need to be.
Have you seen it recover immediately after hyalaise?
Yeah. I have seen, I mean, again, it sounds like we do lots. We don't.
Do a lot of treatment.
We do a lot of treatment, but no, I have seen it just come back, and with rubbing, massage, hot, you know, hot. It comes back bang.
Yes.
But the ones I normally see are referrals, and they're a little bit down the line from other, you know, clinics or around the UK. So they're a little bit further down the line.
Which are more difficult to manage.
They're more difficult, but you can recover it, and you can recover it really well. And that's why I think, you know, your threshold should be pretty low.
Well, thank you for your top tips, Tracy, on occlusion.